Jennifer Finch. I'm a local nephrologist from Houston, Texas. I'm going to be moderating this discussion between Rachael Majorowicz and Dr. Wisit Cheungpasitporn. They work together in the Mayo Clinic. Rachael is a dietitian who actually is an assistant professor of nutrition at the Mayo Clinic. She served on multiple committees, reviews chapters, has a lot to do with redoing the national kidney diet. She's written chapters about the bone and mineral disorders, which we all love discussing. So this is Rachael. Wisit is actually a professor at the Mayo Clinic. He uses AI at the clinic, and he's also has a big role in the ASN, a steering committee member for the ASN's Partnership for Responsible Augmented Intelligence in Kidney Health. He also moderates as the editor of the AI section of the ASN Kidney News. He's Mayo Clinic Professor of the Year for Nephrology. He's recognized by the internal medicine residents. And very interesting, he used AI to develop some augmented educational materials for their fellowship staff and led them to scoring in the top percentiles nationally on their exams. So impressive group. And I think Wisit's going to start with some of his presentation.
Oh, thank you for having me. With the RI, I always learning something new and great ideas from RI. And today, I'm going to share our take from Mayo Clinic. And thanks for having us. So here, our disclosure. First of our session, I'm going to give some idea and my take and what I hope that you all will learn from our experience for the first 5 to 10 minutes, and then I will let the Rachael and Jennifer and have great discussion together, okay? So Mayo Clinic as an institution, we are the academic center, as you know, that really value multidisciplinary. So as a patient come in for clinical research education, we all multidisciplinary approach. And not only multidisciplinary from different the department divisions, but also in terms of the clinical staffs, we also value the nursing staff, dietitians, and also the advanced practitioner that we working as a whole team, okay? As well as our social workers as well. So our clinical staff can lead research in many ways, and also can participate in research many ways in the data collection, for example, or creating the new idea, propose the new idea to us. But I think we have the same the trajectory as the previous the talk, that most of our clinical staff, when coming with the research idea, they always start with how we can improve the patient clinical outcomes, how we improve this. So many of the time that I have seen many successful the research projects from clinical staffs coming from the QI the projects or the evidence-based practice for our division. So the barriers, we're going to discuss more into details, but as you all know that we all have a lot of clinical workload. For example, I had training at Mayo Clinic. I was a fellow when I rounded at dialysis unit. I went to the unit. I saw that Rachael working so hard 5-7 years ago, overtime. Now she's still doing that. So, and I have seen that with a lot of clinical responsibilities, a lot of clinical workload, it's so hard for our clinical staff, dietitian, nursing to pick up or choose to do research. So I think the infrastructure is very important, and also another thing is the mentorship. And as you know that as a nephrologist, when I graduated, I myself needed to find the mentor. But how about the clinical staffs that they need to also looking for mentors as well? It's so hard to do. especially for the clinical staffs as well as the young investigators. So I'm going to give you some final thought later on about the solution of this. So as you see, many ideas, and this is a real, the clinical scenarios that we've seen in every day that, oh, I have this idea, I have that idea, coming from our, the clinical staffs, our nurses, our dietitian, but end up with the projects that got started or funded is very, very few. So what works? I have seen first of all, we need to start it with the leadership support, infrastructure. So leadership need to have the idea that, okay, we're going to work as multidisciplinary, in which our Mayo Clinic have that discipline, that we're working as a whole multidisciplinary. Nursing is important, dietitian important, and we're going to move forward together. The staffs that the studying, we need to identify, like giving some protected time or assignment time. Let's say that, okay, you're interested in this project, let's get started. But giving some time during the working time, not after hours, then that's gonna turn to be next one, which is the burnout, right? So key lesson that we've seen, so QI or clinical practice that gets started turned to be a great the research project that eventually adopted in our clinical workflow. And also, you can start it by giving some protected time. For example, I am also a medical director of dialysis unit and working with advanced practitioner, and there are some selective like funding for advanced practitioner that can apply and then can have like 0.1 FTE to work on research project that like mentored by me, and then let's get started. And of course, you cannot just give to everyone. You give to the person who interested in and motivated in to do that project. So that is also a great idea to get started. And also recognition. I heard from previous talk that is also important, and Rachael is great example of the academia, and we're going to talk more later on. So as I showed you already that the research project, this is all like from nursing and also dietitian, multidisciplinary, that gets started. And this project really adopted into clinical workflow. It's really make the great impact. It's not just like publications one of the publications that I show and publish to the world, but this is really real clinical the practice that we adopted in our clinical practice after this project. And we will talk more after this. And what failed, again, if you just say, okay, this is is your assignment, please do this spreadsheet, we're going to talk about this next month, and you don't really give them time, you really don't give them mentorship or guidance, then it's not going to be successful. It's going to make more of burnout rather than the motivation. So what we're trying to do, and we're working on it right now, is that applying AI and technology into the research. And research is not just only for the clinician or for the physician, but also for our whole multidisciplinary clinical staff, right? So we have AI that help review literature, and also we talked a little bit about the open evidence that can help with literature review as well. And we also employing the AI into, as you know, electronic health record workflow for dietitian, nursing staff. That's making our clinical staff life much easier so they can focus on their works efficiently. So also for the IRB at Mayo Clinic, we just started in October to use large language model and AI to help making IRB much more faster and efficient. So you can start by, do you really need the IRB approval for this project? Is it can be exempted, or is it can be minimal risk? So that can make the IRB process within a week, and or help by using large language model to generate the letter or design the research protocol for your project. And this is all for the clinical staff. So that will help increase the activities from our the clinical staff as a team. And also we employing Mayo Data Explorer. So in the past, when we look into our cohort of the patients, we need to learn how to map the data. But now, for example, you want to understand more about patients who have cystinuria or hyperoxaluria, you can use large language model inside our Mayo Data Explorer. And we also providing education to our clinical staff. So we make research easier to do, basically, IRB approval, and also the research, the project. So I'm gonna turn to Rachael, and Rachael is an example of our dietitian that successful, and the Rachael successful before the AI technology, and so very happy to be her trainee and now working alongside with Rachael.
That's right. Thank you.
So coming back, so we kind of saw an overview of this. So Rachael, now that he's told us all about this, how do you think the lack or presence of protected time helps you do research? And what do you think meaningful support looks like for dietitians, other staff, nurses, so that they can join in on this research besides Wisit just telling you you can come?
Yeah, no, protected time is huge. You know, I look at our nurses on the unit, they're working 10, 12-hour days, and they're tired. They're gonna go home and not think about work and not, think about research and the next thing they can take on extra. So it really comes down to how much of your own personal time do you want to put into things. If you don't have to, you're going to be a lot more productive and get a lot more done at work if you do have that protected time. But how do you find that? Where is that starting point? How can you do that? And, when I was thinking back 20 years ago, when I was just in general nutrition and seeing patients all over the place, and I had back-to-back patients every hour, I had no energy for that either, too. And I remember years ago reading an article published about 3M and how they created all these innovations and how they came up with all these inventions and great ideas. And it came down to protected time. They dedicated 4 hours every Friday for their staff to do whatever they wanted. And that's where the sticky note came from and all these other cool things that we have. And I was like, wow, that sounds amazing. Because currently what you do is if you do have this cool idea or you have this observation in the unit and you're like, oh, I want to look into that, you have a half an hour here, a half an hour there, maybe an hour somewhere, but they could be weeks apart and you're starting all over again by the time you get back to it and try to keep looking into it, and you never gain ground and you never get forward. So that protected time is huge. Our department in nutrition is, in my entire career of 20 years, we've always had something called scholarly activity time, where we do have built-in time where every quarter you can apply for 4 to 8 or how many hours you need to work on a project, even if it's updating our MNT guidelines, if it's working on a research project, if it's for an abstract for a conference. You can apply for that time every quarter and get dedicated time so you can sit down and have that chunk of time, and that is huge. In dialysis, that didn't work for us because there was never anyone that could cover our workload, so we had to get creative. And what worked for me there is I created my own protected time. I can flex my time, I can come and go, and as long as I get my patient care done, and I could take my 40 hours of patient care and try to squeeze it into 30 hours, then I have 10 hours of my protected time that I created for me to sit down and dedicate to creating a branded grocery list for the patients or doing an abstract for a conference. And that's where I started, is just looking at, hey, I want to be involved in these outside organizations. Some of this is my own volunteer time, but some of this is kind of work-related too. How can I build in some of my own protected time there? And that's how mine evolved and came about, and I just had to carve that out of my patient time that way. So.
Okay.
And I need to say that you've done a great job. I know that you're trying to squeeze, but you also like making the all works like really efficient and successful compared to the all of the dietitian staff that I can say that also like all patient care are superb and excellent. So.
Yeah, thank you. Well, I'll add to that too, because how long ago did you go through our program, through the fellowship?
Oh, wow, like the 7-10 years.
Is it
Yeah,
okay? I
yeah.
can't remember. So I've been around for a long time, so longer than that. So he's one of my babies. He's all grown up, and I've trained a lot of fellows over the years. But something that's evolved is like years ago, I remember the fellows would come through the clinic, and they would see their patients and leave. They wouldn't interact with the nursing staff. They wouldn't interact with any of us in the office. They're sitting in the office. They go see their patients and leave. And this is something I brought up to the medical director eventually over time, is that just be like, I think, it's good for people to learn how to work in interdisciplinary teams. And so then this became a requirement in later years, and I can't remember if that was during your time or after, but it was so meaningful after that that then this became a requirement, that every time, every month when the fellows came through, they would talk to the social worker, they talked to the dietitian, they talked to the nursing staff, finding out what's going on with that patient and not just making changes without any of that information. And I found that to be a huge change. So that's something that, when you have a team where you can feel empowered to say things like that makes a huge difference. So again, that interdisciplinary component is a huge part, but empowering your team to speak up. And I have no problem speaking up. I've inserted my foot into my mouth many times, but at the same time, some things are worth it. And examples like that are huge. And I found my way, to insert myself into many things that way now. I do lectures for the medical school. We do the fellowship. I've given lectures for ambulatory nursing, like wherever I see a gap in how we can make our patients' lives better, I'm like, well, what can I do there? And that's the question I ask then is, what do I see and what can we do different? How can I help? And then the team sees you as a value add. They will then start approaching you with opportunities like today. Wisit roped me into today, so because of our interactions in the past. So thank you for that, Wisit.
Yeah.
Thank you.
So,
Thanks.
and drawing on that, I think we can all agree, no matter what spectrum you're in, inpatient, outpatient, hemodialysis, transplant, everyone's moving towards a multidisciplinary approach because in general, the sum is better than all of the parts or more than all of the parts. So can you guys each give an example research-wise where the sum was better? Do you need this? The
Yes.
sum was better than the parts for your experiences?
Yes, of course. And I want to emphasize again that the studies that really making the impact is studies that multidisciplinary and really adopted. So these examples of what we have done that started by the nursing staff, dietitian. So for example, like enteric hyperoxaluria. So we created the workflow that the patients that come in with hyperoxaluria, as you know, they can have oxalate nephropathy, they can have the calcium oxalate stone, right? So the patient need to like have 24 hours of urine and see how your urine, like supersaturation studies look like, how much calcium intake patient should have, how much the fluid and also like the oxalate that need to be limited. And also we have the protocol that created for the nursing team, and our nursing team also like design the workflow that can initiate the calcium carbonate or calcium citrate treatment, and then monitor the patient's urine supersaturation and also titrate those the medication. So these are all can be done by nursing team that we create the workflow, and that making our the clinicians can focus on the clinical part, that how can we optimize to get the best the outcome. Otherwise, you can see also, for example, like PKD protocol. In the past, when the patient with polycystic kidney disease started to have the, as you know, tolvaptan therapy that came in a while back, we reluctant to start it because if we started, how can we monitor? So that is very challenge. Getting our nursing team to involve and then the help follow the patient after the start of tolvaptan, and then titrate the dose, monitor the fluid intake, the urine, the study. Those make our the workflow and patient care turn to be research very successful. Also, I'm going to give the one example of home blood pressure monitor. Now we, as you know, we started to have those like wearable device, and also we have blood pressure, the machine that can Bluetooth information to electronic health record, and a lot of information to the electronic health record. We cannot make this successful without our nursing staff that help monitor the blood pressure and making criteria, what are red flags, and although we can use AI, as the Karin showed us, that AI can process those like blood pressure measurement, but at the end of the day, we need to have the human oversight and review those. So our the nursing team very valuable and review those and summarize and then report to us and make this successful. So I think this is just example of the research and project that really make clinical impact into like the patient care.
And one example I would give too would tie back to what Wisit presented earlier on the lack of time, the lack of resources, the lack of mentorship. An example of the opposite I've seen in our department, the nutrition department's technically within endocrinology. And we have one endocrinologist within the last couple of years who has his own research team, researchers, biostatisticians, and has really become a mentor for the entire nutrition team too. He previously worked specifically with HEN and home enteral nutrition, and they did a lot of publishing and posters at Aspen on tube feedings and all these things over the years. But in the last 2 years, since he's opened that up to the entire department, that number of research proposals and projects that team has worked on has since like quadrupled. And there are dozens of projects going on at any time, from anything from hospital to outpatient, and still those HEN, but now we're looking at hospital renal diets, and there's no evidence behind those, and what are we doing, and how do we study that and make the quality of life for patients in the hospital better. So I'm trying to rope a fellow into that and trying to get involvement. But those are things that we can keep in mind, and reaching out there to find a champion, find someone that will help these, because without that mentorship, without that protected time, and somebody going to bat for those things for us, it does make these things really hard to do, but having those is huge.
So last minute and a half or so, what can you tell us if you envision the perfect platform where AI, computers are working together, and what kind of programs or devices have you used where AI is working, and how do you see it moving forward?
All right, so I think I'm going to approach this question with some of the important barriers that Rachael just raised, that mentorship time, right? The mentorship is not easy to find, I would say, for the clinical staff. So we developing the dashboard. So we in the process of using the dashboard to help, and as we know that one of the AI, the power is to identify the potential, the mentors. So we hoping to develop the mentorship dashboard to match those. And also after that, the research idea is also important. So this can be helped by the AI identify the research question. And as you see that IRB started to incorporate AI, so this part will help the FASN, the process of the IRB, the review for the research. And conducting the research to make it successful, we also have the AI and large language model that help in Mayo Clinic Data Explorer. So we make the process at the initial to conducting the research successful. And not only that, after that, to make the paper, make it happen, I would say mentorship and also more structure that help with the scientific, the writing team.
Yeah, and for the allied health staff in the room, I know we're out of time, but just briefly, they mentioned quickly earlier about open evidence. If you're not familiar with what that is, look into it. It's hugely useful. I just learned about it a couple months ago, and I know others have used it much longer, but it's a great way to do like a quick lit search, and it's gonna summarize the recent literature for you, boom. So, you have a patient with vitamin A deficiency and they have night blindness and they can't drive back and forth to dialysis anymore, and this is a huge barrier to your quality of life, and how do you replete that? And is that really your job in nephrology? But it is, because ophthalmology never catches it. So we need to look into that. And so, you know what I mean? There's all these weird, obscure things that come along, and you're like, this is not in any of the textbooks. This is not in any of the guidelines. What do we do? Boom, you get an answer and open an evidence that is exactly like what we've published in the past or what we've seen with patient care, but again, using our judgment to say, does this seem realistic, doesn't it? So look into that if it's not something you have. A huge resource just to have at your fingertips to look up those things, to be like, what's my next step? What can I do here? If you're looking into starting research, ask AI. Be like, what do I do as a step-by-step process for my AI tool? But I would love to see from a clinical standpoint, like something more proactive in our medical records. Like we spend a lot of time in our assessments right now asking patients all these questions. We spend a lot of time digging through the medical record, even beautiful electronic health records. Be like, oh, my patient's albumin is dropping. Is this nutritional? Is it inflammatory? Do they have wounds? Do they have fevers? Do they have something new I need to know about? Or is their intake replaced? So I'd like Wisit to build that next. Be like, here's all these things that you normally spend all this time looking up. It's going to present it to me, and then I already have it saying, oh, in the last month they have a new wound. They have constipation that's contributing to their hyperkalemia. They have whatever. So I think there's a lot of hope and future in there for AI coming forward in the future to help a lot more too.
Yes, and also I want to take give the last word that as an infrastructure and organization, I think we more emphasize and value in the multidisciplinary. For example, we're going to have KDIGO going to have meeting on AI and technology, and one of the questions that Len and I are going to emphasize and try to find the answer as a whole is how to use AI for multidisciplinary, not just only for the doctor or nephrologist, but for nursing staff, dietitian as well. So that is the important the point that we're trying to address.
Perfect. Well, we're out of time. Thanks to these two. Thanks to Lynn for having all three of us.